As we wait for the participants to join this AOMPT's Twitter webinar number 5, Discogenic low back pain. The low back pain arising from the intervertebral disc, specifically the lumbar intervertebral disc. And lumbar intervertebral disc is special compared to the other levels because it is larger. It has more water content. The nucleus pulposus has more water content. The annulus fibrosus is much more stronger. And you always see that the maximum load of the whole body weight and also the ground reaction force comes to the lumbar intervertebral discs. Shear forces are maximum at L5 S1 because of the line of gravity slightly anterior through the S2, okay, anterior to the center of the disc, okay. So where we have a situation where nucleus pulposus resists the compression forces, okay, and the distraction force or the torsional force is resisted by the annulus fibrosus. Okay? So any kind of a twisting motion or a stretch will always demand the annulus fibrosus to stabilize the segments. Okay? And the joint intervertebral disc is classified under the synchondrosis, the fibrocartilaginous joints, and it is a partially mobile joints. Most importantly, the concentric layers of annulus fibrosis, one layer is arranged like this, the next layer is arranged perpendicular to that. So if there is a rotation in one direction, the fibers will stretch. Other direction rotation, the other layer of fibers will be getting stretched. Okay. So annulus fibrosis has an intricate arrangement. When you talk about the what is called as the pathomechanics, what causes the injury of the disc? It is the excessive compression, the intradiscal pressure. Okay. Especially the lumbar spine has a stability. Okay. It has a model called as the intra-abdominal pressure or the balloon mechanism, which is actually publicized also has core stability. And you see here that the intrathoracic, intra-abdominal, intrapelvic, okay, they have a direct relationship to the intradiscal pressure. And the specific example could be a patient holding the breath, a subject who's holding the breath and lifting a weight. And during the lifting action, if he is doing a breath, he leaves the breath in between. Okay, so that creates which can actually affect the increase the pressure in the nucleus pulposus so that it can herniate through the damaged or the injured annulus fibrosis. Why the annulus fibrosis will go for an injury is because posteriorly annulus fibrosis is abused in the sense we might be sitting in a more flexed postures, which might lengthen the posterior annulus by creep, and the posterior annulus may be weaker, okay, to begin with. So that gets ruptured during the forceful activities like breath holding and then intra-abdominal pressure actions. Even passing stools or coughing, sneezing, okay, it can produce a disc herniation if the annulus fibrosis is weak. Okay. So first and the foremost pathology, what can happen in the disc when it comes to mechanical problems is, of course, kinetic and kinematic, both are there. In the kinetic situation, the nucleus pulposus can lose the water content. Okay, so it has 80% of the water other than the proteoglycans and the glycosaminoglycans. So matrix metalloproteinases and other interleukins, okay, there are various substances, inflammatory markers. They get released when there is a damage to the nucleus pulposus. Okay, the integrity spherical, okay, the jelly substance, if it is intact, then their chemicals will be inside the jelly object. Okay, so you have loss of water there, which makes that jelly substance to lose the pliability. Okay, and because of which it becomes more coarse and more harder and more rough. So it can damage the intervertebral, what is called as the annular layers, okay, which are the innermost layers. It can also damage the cartilaginous end plate, which is above the disc, okay, and also below the disc in the respective vertebrae. Okay, so then what happens is the degeneration begins. Dehydration of the nucleus pulposus itself is the first step of degeneration. Okay, and after which the cartilaginous end plate, again, that is also not innervated. Similar to the nucleus pulposus, there is no free nerve endings. So you will have a situation where the pain will not be produced in this scenario. There will be stiffness. Okay, subject sits in a prolonged flexion posture. Why flexion? Because flexion produces intradiscal pressure to increase. Okay, the compression. So then after that, when the patient straightens up, he's not able to straighten. There's no pain at all. Okay. So this is the earliest stage, disc dehydration. Okay. After that, the disc, what happens, loses its chemical property because the water content is altered, and then it becomes more harder, and then it damages the articular cartilage, the cartilaginous end plate, and the inner annular fibrosis. That is called as the disc desiccation. Okay. Dessication. So degeneration, then desiccation. After that, that disc material which is desiccated can produce a damage to the subchondral, okay, the bone which is in the vertebral body, leading to a herniation into the vertebral body, which forms what is called as the small node, SCHMORL, okay, apostrophe S, named after the scientist who discovered that. Small node that is also into the vertebral body, especially if the vertebral body is osteoporotic. Okay, so in that scenario, you will get the disc material, going into the vertebral body there. Okay, mostly it goes to the proximal vertebra. This is the degeneration, but when it reaches the subchondral bone, then the pain starts. Okay, the early morning stiffness, and also it eases with movements, the characteristic features of a degenerative disc disease. Okay, especially during flexion extension, where a sustained flexion might produce a stiffness, and the patient gets up and starts walking into the extensions, or lies down in prone in extension, or remember that movements will actually enable the recovery faster than the positions. Okay, because movements redistribute the water, and because of it, the jelly nature, a little bit temporarily it is restored, so the mobility will be restored, so the patient feels that movement is free. Okay, so stiffness can be accompanied with pain if there is damage to the subchondral bone. Annulus fibrosus, on the other hand, anterior annulus and posterior annulus, inner annulus and the outer annulus. Inner annulus is not much innervated with the free nerve endings. Outer annulus is innervated better. And in the outer annulus, it is the posterior annulus which is more innervated than the anterior annulus. So a flexion posture will elicit more pain because posterior annulus is getting elicited, it's getting stretched, it might get a micro trauma called as the strains of the annulus fibrosis. Okay, strain is a sustained injury, okay, prolonged injury. Sprain is a sudden twist stretch injury. So that is sprain, annular sprains. That happens with trauma. Okay, we have a road traffic accident or bending and rotation and then lifting, the annular sprain. Okay, minimal injury, and there is a pain which may be a referred pain, but 3 to 4 days spontaneously it recovers. Okay, with an active recovery period and then a protected rest. Okay, not a full bed rest. Okay, and this situation, you see that the patients do have pain, but they have manageable, self-manageable, and it's easy to get through with that condition. When it goes to annular strain, which is a sustained mechanism of injury, and then it has a low back pain, the patient has to correct that with sustained positions of correction, either like prone lying or keeping the back support, and then you feel upright and erect throughout, you maintain, then you feel that better. Okay, so that is actually matches with the postural syndrome of Robin McKenzie's mechanical diagnosis and therapy. Okay, and after which, when you talk about that posterior annulus is stretched, anterior annulus is compressed. Okay, so this is the scenario because of a prolonged flexion posture. Strain has happened, it has healed, but the annulus is more lax. Okay, the length of the annulus, resting length is changed, it is more, and with that weaker annulus, then what happens immediately is the multifidus inhibition starts. Okay, so that segmental atrophy of the multifidus further accelerates what is called as the instability segmentally. It's mostly anteroposterior instability, which happens because of the annular strain. Okay, and this stage, if the symptom has to come, the symptom will come because of the instability in terms of all the transitions getting symptomatic in the mid range, and also range itself can be excessive. Flexion range can be excessive, or extension range can be excessive. That is called as the mechanical instability. This is a discogenic instability. Okay, so this is also highlighted in the recent published article of Journal of Manual Manipulative Therapy. I'll share the link in my retweet shortly after sharing this webinar on the Twitter platform. What is important here is, remember that you are having a stretched or lengthened annulus fibrosis and it is weak than the original fibers. Okay. So then nucleus pulposus, which are actually lost to the water, the degeneration or the desiccation, what has happened is it starts creating the friction from within. The inner layers get damaged. Outer layers are intact, but they are loose and lengthened. Okay. So inner layers are damaged, but outer layer is intact. So then it causes the protrusion, disc protrusion. Okay. So after annular strain, the next is the disc protrusion. There what happens is it is mechanical presentation because flexion might produce the protrusion. Posteriorly, the nucleus pulposus migrates, but an extension or an extension position again gets back the nucleus pulposus to its original position. So here again there is a mechanical behavior. It might come as under the dysfunction syndrome of the mechanical diagnosis and therapy of Robin mechanism. The next, when we come to what is called as the rupture of the annulus fibrosis, okay, whereas posterior longitudinal ligament that also is ruptured or the split happens. Okay, there is a two bands are there. Okay, both the sides, lateral bands. So they separate, and through the center, the disc material can herniate. The nucleus pulposus can herniate. The condition is herniated nucleus pulposus even when it is in protrusion, but now it is extrusion because it is outside the posterior longitudinal ligament. Okay, and during the extrusion, the chemicals of the nucleus pulposus directly are exposed to the anterior dura mater. So what happens is more constant pain comes because there is a chemical stimulation. Okay, chemoreceptors gets activated. So constant symptoms, and patients have what is called as non-mechanical presentation. They might have a referred pain throughout the back, and during the flexion and the extension, it will create a localized pain. Or they might have distal symptoms, both the sides, bilateral radiculopathies, or even myelopathy. In the upper lumbar, it is myelopathy till L1, L2. L2, it is becomes a conus medullaris syndrome because spinal cord ends there, and it is combination of UMN and LMN, conus medullaris. L4, 5 and L5S1, it causes the cauda equina syndrome. Okay, that is, these are all classified as part of the spinal cord injury. And if you have myelopathy, it is upper motor neuron where we have hypertonia in both the lower limbs because of the disc bulge, which is posterocentral disc bulge or a disc protrusion. And after which you see in terms of what is called as bilateral radiating pain, then you think in terms of, then you ask the questions of bladder and bowel problems, and then you see whether tone is less, reflexes are diminished. You can talk about what is called as the lower motor neuron, the cauda equina syndrome. Okay. If it's a combination of upper motor and the lower motor neuron, okay, bladder is affected in upper motor neuron, but the tone in the lower limbs is flaccid, hypotonic, reflexes are diminished. You can think in terms of conus medullaris syndrome at L2-3 or L1-2 disc. Okay, so here central, posterocentral disc herniation. After which we come to the posterolateral disc herniation, which is more common, where it is the foramen, the nerve root compression, which can happen. Posterolateral disc herniation, the mechanism of injury is flexion rotation. So the patient or the client bends and then tries to lift an object. During the lifting, they do with the rotation and they come up, and then they get the catch in the low back associated with the shooting pain unilaterally. Okay, so the posterolateral disc herniations affect one side nerve root, which causes the shooting pain or radicular pain in the lower limb, called as the lumbar radiculopathy. So discogenic radiculopathy, as we saw discogenic instability, and we saw the degenerative disc disease, okay, which is degenerative disc disease is under the spondylosis. Okay, discogenic instability is under the spinal instability, which is either mechanical or clinical instability, because clinical instability will come if multifidus inhibition and the transverse abdomen is also altered recruitment. Okay, muscle control recruitment abnormalities, control impairments are called as the clinical instability, whereas the movement impairments, which is hypermobility, they are called as the mechanical instabilities. Okay, where the range is excessive, where you might prefer to give a lumbar belt for maybe 3 weeks. Okay, just to limit the excessive range of motion. Coming to the discogenic radiculopathy, Remember that in radiculopathy, which is posterolateral, the symptoms will be predominantly in the lower limb, and it may be dermatomal distribution. It may be little bit out of the dermatome, mixed can happen. Myotomes weakness, the key muscles supplied by that L5 means extensor of the great toe, S1 means the plantar flexors or avatars. Okay, so these all muscles, key muscles are the L2, 3, 4 means the quadriceps. Okay, so these are all myotomes have to be tested. Okay, not only that, reflexes. Knee jerk will show L2, 3, 4, whereas ankle jerk will show S1. So you need to assess all this neurological examination together whenever there is you are suspecting a cauda equina, myelopathy, or you suspect a radiculopathy. Okay. Next, when it comes to the foramen compression and then symptoms, posteromedial disc herniation is there. Imagine that this is the dura mater, my trunk. Okay, posterocentral herniation will affect the dura mater. Posterolateral disc herniation will affect the arm or the shoulder. So it's only the nerve root which is affected. But there is something called as posteromedial, which can affect the dura mater and also the nerve root. Okay, these are called as axillary disc herniations. And posteromedial disc herniations have a different behavior because the patients will have back pain and also leg pain, where the back pain is more in intensity than the leg pain. In posterolateral, the back pain and leg pain may be present, but the leg pain will be more than the back pain. Okay. In posterocentral, only back pain will be there. And there is another type, far lateral disc herniation. So that is only the nerve root is getting compressed, where you will have only the leg pain. There will be numbness and tingling in the distribution. The S1 means it is the calf muscle. Okay, there you will find the distribution, there symptoms. Okay, how do you say a referred pain from a radicular pain? It's very simple. When you do the neurodynamic testing, okay, especially the SLR, when you do a straight leg raise in objective examination, okay, when you do a compression distraction test, that is also there in objective examination or physical examination. We have accessory mobility test of Maitland, Jeffrey Maitland, spinal mobilization assessments. So that is also important one for the disc. And the motor control or the movement control tests. Okay, these are also very, very important. According to Peter O'Sullivan, or it is the Hannu Lumayoki, the movement control test. Okay, or the what is called as Paul Hodges or the Gwendolyn Jull, their approach of multifidus activation using pressure biofeedback or the real-time diagnostic ultrasound imaging. Okay, so we give a contraction to the multifidus and then we assess. So every assessment is part of the disc problem there, in addition to the neurological examination. So when you come to the exact findings there, compression test and distraction test, these are important for the nucleus pulposus. Okay, symptoms will aggravate on compression, axial loading. Okay, even a person who is traveling with a vertical load, vibration load, okay, on an uneven ground, okay, they will have disc pain when that is severe pain is there. When that severe pain will be there, when there is extrusion, chemoreceptors, and these subjects will have what is called as the muscle spasm. Okay, extrusion and sequestration will have muscle spasm. Okay, so the catching pain will be there in the back, and the subjects will resist any kind of a movement in any direction. It will be paining because it is not mechanical; it is chemical, chemoreceptors. So it's not one direction. Okay, every direction it will pain. There won't be any specific centralization of symptoms or peripheralization of symptoms in extrusion and sequestration. Sequestration, in addition, will create symptoms irrespective of mechanical stimuli. Sometimes in the night, the fragment might be moving in the subarachnoid space, the epidural space, okay, the disc material. So the pain can be felt anywhere in the body there. Okay, so it's really very disabling for the patient. But you have to make sure that we identify the type in our clinical findings itself. If you find an extraordinary, exaggerated symptom presentation in the low back, in addition to the low back, it is there in the whole body, okay, and the patient is really not allowing you to do any kind of a movement test, you touch also it pains, okay, and you divert the patient, okay, patient is looking somewhere, then also he's not allowing you to touch. If you touch means he gets a burning pain, okay, allodynia, which is unaffected by the diversion, okay, attention diversion. It means that central sensitization. Okay, so go back to the previous webinar where we have discussed about pain neuroscience education. So that's a very, very important method for central sensitization in chronic low back pain. Chronic by mechanism, the central pain mechanisms. Okay, so that can also occur in disc. Most importantly, why it occurs is because patients go to the consultants and they are shown the MRI, they are shown the skeleton with the disc material that is prolapsed. So the subject gets that cortical representation that structurally it is abnormal, structurally abnormal. Okay, so that reinforces their neuroplasticity in terms of pain memory. Okay, so that creates a hypersensitivity or hypervigilance to the pain, and that maintains the chronicity irrespective of the duration. Otherwise, this material should heal in 3 months, but these patients will have pain even beyond surgery also. You remove the discectomy, okay? You remove the lamina, it's a decompressive surgery, laminectomy, which is both are performed for the disc prolapse or radiculopathies. For laminectomy, we do that for the radiculopathy. Even then also patients will still have the pain because there is a minimally invasive procedure called as chemonucleolysis. Okay, so we have a chemicals injected into the nucleus pulposus, which actually makes the nucleus pulposus to be fibrosed. Okay, so there is nothing that can bulge and they can compress the painful tissues. That surgery also, any of the surgeries do not have a good recovery. Even if you have a fusion, still the patient has symptoms, failed back surgery syndromes. Why? Because it's not just the peripheral mechanism, there is a central mechanism which has to be addressed. So that's why we are exploring that pain neuroscience education, which has good level of evidence. So kindly get your knowledge updated and use these techniques. In patients who are malingering, you find that they are non-organic, they are psychogenic, purely they are mimicking the pain. You have to utilize cognitive behavioral therapy. Okay, so that's something which is an additional toolkit which you have to keep yourself trained on, so that the patients can be benefited and ethically we can manage the condition in order to improve the productivity of the younger age group who are having the back pain. Okay, so compression distraction, nucleus pulposus, aggravation relief. And then we come to annulus fibrosus. We test with the shearing force, the movements. So mainly the central posterior pressure we give on the spinous process, okay, which creates one vertebra to actually move postero-anterior. So segmentally, it creates a flexion of one vertebra over the distal vertebra, okay, and it creates the extension with respect to the upper vertebra. Okay, so both can be checked simultaneously. That is by Maitland. You can check the disc with that. If you want to check the foramen, intervertebral foramen, and you are suspecting a posterolateral or posteromedial disc herniations, you have to do transverse vertebral pressure. That means the vertebra is like this, the spinous process, and this is the spinous process. This is one transverse, another transverse process. Okay, so from here, this is the vertebral body. Okay, the subject is prone. You can give from the side the transverse vertebral pressure, which makes the vertebra to rotate, and the vertebral rotation to the same side will open the foramen. Okay, in L5S1. No, L1 to L5. Pardon me. Okay, L5S1, the opposite side rotation will open the foramen. So that means if I have a right radiculopathy, left rotation will open the foramen in L5S1. Whereas L1 to 5, right rotation will open the foramen in right radiculopathy. Okay. Whenever you have a disc bulge L4-5, it will affect the L5 nerve root. Okay. And if it is L5-S1, it will affect the S1 nerve root. S1 nerve root condition is called as the sciatica, the S1 radiculopathy, the true sciatica. Okay, that is because of the foramen compression. The pseudosciatica is piriformis syndrome, which is much more distal, below the sacroiliac joint, near the hip. The piriformis muscle, which goes for a myofascial dysfunction, leading to the compression or entrapment of the sciatic nerve distally. Okay, it's not only the S1 root; it is S1 to S5 and C1. All of them form the sciatic plexus. Okay, sciatic nerve. So distribution beyond the S1, if there are symptoms, then you should suspect that it is distal. Only S1, if the symptoms are there, then you should suspect higher true sciatica. When you do an posture assessment, the scoliosis, okay, there may be a kyphosis if there is a posterior herniation, posterior posterocentral. But if there is a posterolateral, subject might bend away from the symptoms in order to open the foramen. Okay, keep the foramen open. So some patients do bend towards the same side. In case of posteromedial disc herniations, they bend to the same side because it opens. Okay, same side. But if it is posterolateral, same side they cannot do bending. Ontologically, they'll bend to the opposite side. Okay, so you should be clear of whether the symptom side is right. So the spine is bent towards the right or away from the right. You can hypothesize whether it is posteromedial or posterolateral disc herniations. Kyphosis is there, definitely posterocentral. If it is hyperlordosis, you should suspect that it is the anterior disc herniations. Okay, it's very rare. These are all classified under the derangement syndromes of McKenzie's mechanical diagnosis and therapy. Okay, so when we come to further identification of the disc lesions, remember that you know the annular, you know the nucleus pulposus, you know posteromedial, posterolateral, posterocentral, and anterior, far lateral also. Okay, only lower limb. But remember that mechanical versus inflammatory behavior, it will influence whether centralization or peripheralization is happening. Okay, in an extrusion or in a sequestration, you will not find centralization or peripheralization. So in such patients, you should do traction, manual traction as an assessment. The legs you can just pull. So then what will happen if the relief of symptoms is there? You can give intermittent lumbar traction. Okay, you can give gravity assisted self traction where the lower limbs are hanging and then the subject is holding the plinth so that the body weight gives the traction there. Okay, and then next one you can think about mechanical treatments, which is to do with directional preference. So assess whether flexion is centralizing or extension is centralizing, because in some patients who have degeneration and they have posterocentral where there is a stenosis, okay, all the canal is narrowed because of the disc material. Those patients will have relief of symptoms with flexion. Okay, so flexion will centralize. And if patients who have a compression only one aspect of the dura, what will happen in flexion? They will have peripheralization. In extension, it will be going back. So they will have centralization. So you will give what is called as the directional preference based exercises, extension regimes or the flexion regimes. Okay, this is the traditional concept. What is important here is not to forget the instability. So always incorporate the stability training. Okay, so involve the motor control, train the multifidus with pressure biofeedback, train the transverse abdominis by palpation, co-activation with the diaphragm and pelvic floor, with the posterior fibers of the internal oblique. So get sure that you have the stability first. That has actually the mechanofunctional diagnosis and therapy, MFDT, of the AOMPT, the registered approach. So next, what you see in terms of the treatment is incorporate the flexion or extension in a functional pattern, okay, involving 4-point kneeling or squatting, okay, proximal to distal variation, distal to proximal variations. You can also see sometimes combined motions directions can be centralizing better than only the extension. You can have an extension with lateral flexion to opposite side, or you might have a rotation to the same side. These combinations can centralize, okay, in L1 to 5. So if that is the case, maintain the combined position, incorporate the Edwards concept of combined movements, okay, and then make sure that if you have a radicular symptoms, keep the nerve to be calm. There should not be neural symptoms which is peripheralized, excessive numbness which is felt in the leg. Okay, you should not be keeping the patient in that position. You should always position the patient in centralized position. So keep them, and then you can utilize the offloader of the sciatic nerve. You can keep the hip abducted, externally rotated, and knee flexed, and ankle plantar flexed, and hip extended with the pillow, okay, in the prone position. So this position is an offloader for the sciatic. And if you want to increase the loading, you can go for the slider techniques of the SLR. Remember that the straight leg raise, you do it. Sometimes during the straight leg raise, only the back pain will come. So you can suspect that it is posterocentral disc herniations. And when you do the SLR, if back pain and leg pain both are coming, but back pain is more in intensity, you can suspect posteromedial disc herniations. In such patients, crossed SLR, opposite side, normal symptom, asymptomatic side, you do the SLR also, symptom will be reproduced in the radiating pain side. So that is the cross leg raise or the well leg raise test positive. It's very highly specific test, okay, to diagnose that there is a disc bulge is crossed SLR. If crossed SLR is positive, when you are lifting right leg, left side radiating pain is coming, you can blindly say 96% it is specific to rule in intervertebral disc prolapse. Okay, so you can be sure posteromedial disc herniations. In the SLR, if you have symptoms only on the leg that is lifted, not on the other leg which is supported on the plinth, so that means that it is a posterolateral disc herniation, and leg pain, leg symptoms will be more than the back symptoms. Okay? And you differentiate with ankle. You can also do the slider techniques of the SLR itself. Okay, you have neurodynamics, you have sliders. Then after that, progress to tensioners. If some patients do have negative SLR, that means 0 to 30, if you have an SLR positive, suspect a muscle spasm there, so it's not allowing any kind of a movement. But 30 to 50 degrees, you can suspect initially S1, then L5. Okay. So you have a 30 to 40 is S1, 40 to 50 is L5. After that, 50 to 60, you have this L4, 3, okay, that higher levels. And even L2, 3, 4 can be found by positive by prone knee bending test. Okay, the femoral nerve stretch test or the Elise test. So remember that you have to incorporate various neurodynamic tests depending upon the level that you suspect by accessory mobility testing or by neurological examinations. Okay, and next one, what you see in terms of this SLR is when the SLR is negative, 70 degrees it has come, and there is no symptom at all. Then you suspect that hamstring tightness after 70 degree it might affect the range, or the sacroiliac dysfunctions, which is coexisting with the disc bulge. Remember that the same side of posterolateral herniation, you can also have a facet joint dysfunction, which is a flexion lock, open lock to facet. So you have to treat the facet joint dysfunction also by unilateral post-anterior pressure techniques of Maitland or muscle energy techniques. Incorporate that. Uh, After the disc is recovered, the radiating pain is recovered, you can give a thrust manipulation to the facet also. Okay. By that time, if the facet joint is not getting recovered. Okay. So make sure that you incorporate parallelly, pathomechanically, you understand the associated structures that are getting injured and affected after differentiating central mechanisms. Okay, then you go to peripheral and you go to articular, myofascial, and neural. There can be trigger points that is present even in the multifidus itself or in the erector spinae, which are in spasm. They can have active trigger points, but they are not the primary one. So treat the disc automatically; they should disappear. They should calm down. But sometimes in chronic patients, this myofascial dysfunctions restrict the corrections. So there you can give myofascial releases and even muscle energy techniques for the erector spinae, okay, to lengthen them, post-isometric relaxation techniques. Piriformis, which is again another notorious muscle, it can coexist with trigger points in patients with radiculopathy, causing a double crush syndrome. S1 is compressed in the L5 S1 foramen, and sciatic nerve is compressed distally by the piriformis. Okay, so both can coexist. So don't miss assessing the piriformis. We are going to have a separate webinar, interactive webinar on piriformis syndrome. So try to explore this aspect, and then what you do is SLR is negative, you will check the slump test. Okay, slump test is performed in sitting, and patients have do have symptoms when you do the knee extension, ankle dorsiflexion, unilaterally or bilaterally, in the midline, in the back also. Non-radicular low back pain. That means only low back pain is that posterocentral disc bulge. Patients can have positive slump test. Okay, so don't miss that assessment. And the next part which you'll actually incorporate is a combination of articular, myofascial, and neural, which is like in the slump test position, you can give a central PA pressure on the spine, articular. Slump position is neural, and in that you can make them to activate the force closure, that is the core stability, the diaphragm, pelvic floor, transverse abdominis, multifidus, posterior fibers of the internal oblique. What happens is it becomes arthro, myo, neuro, manual therapy. Okay, AMNMT approach of the AOMPT. It's a combined multi-structural approach, which you should explore. Okay, how much you can use it in progressions or in handling of athletes with disc bulge and radiculopathies. Okay, so that way, if there is a centralization, peripheralization not there, you check the traction. Okay, manual traction. It will indicate the traction subgroup, and you can then subsequently manage the patients with the instability approach, stability training. Then go for directional preference as it appears, and then you go for functional immediately, because The faster you translate the motor control into functional, the patient is going to get better. That is functional neuromuscular stabilization training of the AOMPT. There's an extended approach incorporating all the motor control approaches. Okay. And what happens when you translate to the functional recovery? It's you can give prescription of aerobic activity for the patients and incorporate that into their daily regime so that they do not need to do specific exercises. Okay, so their daily activity is more than enough, and get the fear avoidance or kinesiophobia handled well. Incorporate mental imagery for a faster recovery. Okay, central to peripheral, and also incorporate activity pacing. Okay, so to monitor which activities, how much activity is producing the symptoms. So try to keep doing 60% discomfort till that level they can do the activity. Take some extended rest periods and again come back to the activity. So that's important for recovery. Don't give an extended bed rest beyond 3 days. Okay, except if it is cardiac vena syndrome where you want to give a brace and then keep it for 3 weeks. But even then, you will have to keep strengthening the lower limbs, chest, everything, so that the patient is fit to get functional recovery as fast as possible. Okay, and investigations for the disc. The most important investigation, most reliable investigation is the ultrasonography. Okay, don't think that it is the X-ray. X-ray will tell degenerative disc disease maximally. MRI is very poor. It is for specificity and also sensitivity. Normal subjects like us will have a disc bulge, massive, and at the same time, people who have symptomatic severe pain, low back pain, disc will be normal. Okay, both the situations are common. So don't go by the MRI. Also, surgeons might focus the patient's attention towards the MRI. Don't contradict other professionals' opinions. Okay, their school of thought tells about anatomical. Our school of thought tells the biomechanical. Okay, so try to communicate only functional terminology and try to modify the mechanics. Tell the subject that sitting and standing and walking, your activities are the ones which are altering your symptoms. So it is not a structural problem, it's a functional problem. Okay? So we are going to modify the activities, we are going to make you conditioned to perform the activities better, and that's the way you are going to recover so that the patient will be compliant with the exercise regime. And you should be aware of what is called as the coexisting problems, the sinister pathologies. Instability is present, or it is going to be a degeneration, or you have a radiculopathy with stenosis, okay, which creates an intermittent claudication. Patient walks for some time, after that gets the radiating pain. So you might have to give flexion pattern or foraminal enlargement, but don't decide by the condition, decide by the directional preference. Okay, so see which direction is centralizing the symptoms and then prescribe those exercises. Lower extremity flexibility, whether it is really an important factor, research could not find a relationship between that, but load on the lumbar spine might be increased more if the lower extremity is more stiff. So you can go for myofascial releases of the lower limbs and then go for aerobic prescriptions. Don't go for a passive stretching. Okay, I don't advise that for lower limb. So that's always better that you go for active physiological conditioning. Okay. So coming to mobilization techniques, central posterior pressure. Yes, at the level that is painful, you give grade 1 and 2 mobilizations. Level which is restricted, it is stiff, you can give the 3 and 4 mobilizations. Okay, hypermobile levels, don't give the mobilizations, and you give the stabilization training, multifidus conditioning, okay, reactivation. So you can use real-time diagnostic ultrasound in order to ensure that the multifidus fiber thickness changes in response to the training, so that you can be sure. If you are giving a postural re-education, postural retraining, any kind of methods, use the EMG biofeedback. Make sure that the posture correction actually relieves the symptoms. Okay, you should find a direct relationship on reassessment. Okay, so don't miss that. The last part which you have to take care is the home program, where the patient has to take care of multiple activities, like it may be stair climbing, it may be even bowel, bladder care, okay, stool, passing stool. So they might be apprehensive to make an effort. So the disc bulge can happen again, or even a sexual activity, okay, with the partner. So sometimes you might have to give some ergonomic advice for addressing all these activity related problems. Otherwise, refer them to an occupational therapist if you are not competent enough to handle the daily living activities. Okay, you want to retrain them. Okay? So that way, bracing is not advisable unless there is a trauma, there's a road traffic accident, and then there is a disc bulge, or you have a mechanical instability where the range of motion is excessive, and patient is also another elderly that you can't operate, you cannot give exercises. Okay, cognitively not much sound. So then what you can do is give the brace, and then you can functionally mobilize them. Okay, because if you keep them on bed rest, the osteoporosis is going to accelerate more longer, more it's going to worsen the patient condition. So you will prefer to mobilize, early mobilization. Okay, so think about multiple aspects, try to get the plans set right. Okay, it's not that disc is the only structure that is leading to the low back pain. Okay, we have ligaments which can lead to the low back pain, which can, we can have the facet joint syndromes, we can have myofascial pain syndromes, and irrespective of the disc problem, also radiculopathy can come from osteophytes, which is from the spondylosis. Okay, so syndesmophytes come from the disc because of the degeneration, whereas osteophytes come from the facet joint. Okay, from the posterior part. Stenosis again from osteophytes is also common, and sacralization, lumbarization, these are all conditions which you should be aware. Spondylolisthesis, grade 3 and 4 will create discogenic instability, which can cause radiculopathy. Okay, otherwise, 1 and 2 may not cause disc lesions, and maybe most of the cases it will be asymptomatic. Okay. So I have given a full overview of this condition. I am expecting more queries from all of you when I retweet it. Okay, in your reply to this video, you can always put your comments, okay, asking queries, so that I can reply it directly on Twitter itself. Those who wish to have the e-certificate of participation for this webinar, Discogenic Low Back Pain, should contact me on WhatsApp, the number given. So you register yourself with submitting document proofs of your physio or student identity cards, so that AOMPT can issue the 1 hour of e-certificate of participation for this webinar. The total webinars, all the webinars are free on Twitter, 31st March till the 31st March. Further suggestions for future topics related to musculoskeletal or manual therapy is also welcome from all of you. The experts who are watching from around the globe, including Julie Fritz, Joshua Cleland, Paul Hodges, all are connected with me in Twitter. So please welcome to provide your inputs. In fact, Professor Jean-Michel Brisby, the chief editor, is also there on Twitter, and Professor Pointedura is also in the associate editor for the JMMT editorial board. We have a global community connected on Twitter. I am open to receive the inputs, so that we can discuss further along to improvise the evidence-based practice in application of manual therapy for discogenic low back pain. Okay. So I'm ready to now close the session and invite all of you to provide your inputs, comments, and suggestions to improvise the knowledge base for this condition. Good luck.